Thank you for the nice introduction. Thank you for the invitation. I'm very happy to be here at this wonderful place and to discuss with you our thoughts on treatment of neuroblastoma, in particular in patients with relapsed neuroblastoma. Today I'm dealing with immunotherapy, and I have first to disclose that I got some financial support from United Therapeutics for a recent symposium which we held at the SIOPEN conference in Cape Town, and here this travel to this site is supported by NCCA. Neuroblastoma, you know, it's not the topic here of this conference, but we have at least two different patients with different biology, the good and the bad. And as you here can see, the incidence of the patients with high-risk neuroblastoma is different, but there is some overlap from age, but also overlap, of course, from the biology. And I think we should not forget the other part, because we can learn from the other part also how to deal with the high-risk patients. Death from cancer is still the second most frequent cause for death in childhood. And within the cancer death in childhood, the second most frequent cause is neuroblastoma. First is leukemia. You know, leukemia has much better outcome, but has many more patients. So 21% of the ALL patients or 21 of the cancer deaths in childhood is from ALL. But second is neuroblastoma, then followed by AML and by soft tissue sarcomas. Did we make progress over the last decades? This is a recent publication from COG, which includes also other patients, and you see here it looks somehow encouraging. So we made some progress over the last 20 years, but this includes all patients with high risk, also those with localized disease and amplification, and also those patients which have a poor histology, so Shimada high risk. And if we go a little bit closer, then for the focus here of this meeting and of course of the different trials in the world, so then the numbers, these are here from German data, are less convincing. There is of course some progress, and it's also fine. The 5-year survival has improved over the time in the overall survival. But if we go a little bit closer, even more, then look at the event-free survival, then you see that the curves more or less overlap for the last year. So we still not at the stage where we want to be, and we need really new thoughts and new approaches. And if we go even further, relapse from stage 4 neuroblastoma over the age of 18 months at diagnosis. Then you see that the curve drops dramatically down. Progression-free survival is approximately 6%, and the 5-year overall survival is approximately 10%. This is a large study with 522 patients. So this is a retrospective analysis. But you see, if you look at just at the time from first recurrence to second recurrence, this is only 4 months. And if you look at the time for the median time for survival from first recurrence to death, then it's close to 10 months. So that is small. And that's the point where we start from. And though, is there no hope for children with recurrence? But there is. Here you see that the approach for the treatment is quite different, or maybe quite different. And this is more or less a decision together with the parents and the and the pediatric oncologist in this part in Germany, but I think this is very similar all over the world. 1/3 of the parents decided not to get to another curative approach because the side effects and outcome perspective, and they of course have a very poor survival. These are the curves, which is a little bit more than half of the patients who got a second approach of chemotherapy plus something other, including antibodies. And the best survival so far is for patients who got chemo and responded. This is a prerequisite. They responded to the chemotherapy and got second transplant, and then you see at least 20% had some realistic chance to survive. But this is only 20% of the total population. That's also very important. I'm not dealing with the many approaches which are possible now, with including MITG, ALK inhibitors, Aurora kinase inhibitors, other inhibitors, so just with the bottom here of this is immunotherapy, which has been covered also by Daniel and Andras altogether. I think John Kenshet may be some of you well known here because he was a researcher at Ralph Ormond Street and later at Bristol. And we had together in Sao Paulo at SIOPEN conference, and there he stated very clearly, back in the early 80s, we were very naive in believing that monoclonal antibodies were the universal panacea for treating patients with malignancies in general. 20 years on, the view is more discriminated or is different. So we had quite good success with leukemias and with B-cell lymphomas. That was with rituximab, for example, was great success, but for this great disappointment in general with solid tumors. And the question arises, is minimal residual disease, as it was pointed out today, also the adequate target? And last year at the AMR conference in Cologne, Sally McCall stated, I think, another part which is very important. We don't have only genetics. We have a very individual patient with an immune system, and the immune system, of course, plays also an important role. And this important role is not static; it is dynamic, and it is very patient and situation condition related. So we have to consider this. You have seen this type of cartoons already, so the main players in anti-tumor response, in particular for cellular therapies, including T cells, natural killer cells, and the tumor-associated macrophages, which are derived from the monocytes in the blood. And we just had 2 excellent talks on the chimeric antigen receptor, the CAR T cells. I don't have to elaborate on this. There is a big success again in T cell leukemia and also in lymphomas. So this is really encouraging. So I think this still has to be worked on and to show the proof of principle also for the solid tumors, including neuroblastoma. What has also been mentioned today already, cellular therapies to generate graft versus tumor effect. Again, graft versus leukemia effect is well recognized for many periods, many decades, but it still has some question marks in solid tumors, in particular with neuroblastoma. We think there may be some effect, and have treated patients with NK cells, allogeneic stem cells, and haploidentical stem cells. So haploidentical technique is, as mentioned today, from the parents, and they produce NK cells, natural killer cells, which attack the neuroblastoma cells in the body of the patients. Also, I have not to cover the dendritic cell vaccine, which targets MAGE1, for example. Some specific antigens which are also on neuroblastoma cells, specific antigens MAGE1, MAGE1A1, A3, and NYA, so together with decidedly, and murine anti-idiotype tumor vaccines, including anti-GM3. Now I come to the anti-GD2 antibodies. This is probably most interesting here for the auditorium. And there are a few antibodies now available. It started with the CH1418, which has been developed in La Jolla at Ralph Reisfeld's lab. Now the unitoxin, which is approved for Europe, also not only for COG and available, commercially available. Then the CH1418 GPOH, which is used in the which is produced by iron and used in the SIOPEN studies, and the New York antibody 3F8 and 8H9. It is proven for those antibodies that they have an antibody-dependent cellular cytotoxicity, complement-dependent cytotoxicity, but not only this direct on the tumor, but also it changes the whole pathways, the signaling pathways, including the PI3K ACT-mTOR network. So it's just more than targeting one specific molecule on the tumor cell. To augment the effect of the antibody, early on has been used IL-2 to augment NK cells and ADCC, and GM-CSF to augment the myeloid effectors and ADCC. Naikomcha from Sol Kettering has pioneered this work in vitro, but it has been then taken up for the immuno study. I think it's now clear from several studies that IL-2 alone, infusion of IL-2, or maybe even the NK cell is problematic, has limited or no effect, at least not in heavily pretreated neuroblastoma patients. So Kettering has also, Brian Kushner, worked on intrathecal radioimmunotherapy, and there are encouraging results for intrathecal administration of radio-labeled antibodies, but one has to admit that this is not the only treatment. It has also chemotherapy and external beam irradiation. So we have to be cautious to allocate the effect only on the antibody. There are different strategies to make the antibody more associated with less side effects and to keep the efficacy. That is the fusion protein with IL-2, then the complement activation blunted antibody, and to use GD2 as an anti-tumor vaccine. This could be used with a surrogate, but has been also used to increase the response to the GD2 by adding GD3 and beta glucan. Anti-GD2 has been used with chemotherapy together with irinotecan temozolomide and also with an immunostimulant, the lenalidomide. First, I have to say that not the different now available two or three antibodies are the same. The epitope, which is recognized, may impact the therapeutic efficacy and also the different binding constants. So the binding, how tight the antibody is bound to the molecule to the GD2 molecule on the surface of the neuroblastoma cell, and this may impact therapeutic efficacy. We know that antibodies against these, which are type of neutralizing antibodies, can markedly change the distribution and also have effects on the efficacy of the in vivo in the patient. These are the early studies which started to have evidence that anti-GD2 antibody may have effect in patients. One of the earliest trials, it's not the first, but one of the earliest has been done by Rupert Kretinger, and he showed that in refractory, severely pretreated patients, 9 of them, 6 achieved a partial remission after recurrence. This is quite a lot, but could not in larger studies repeat it. Then pioneer work from Sloan Kettering with the radioimmunochemotherapy. Here, this is the earliest trial from Naikong at Brian, showing that of 16 patients, 3 survived and the others had prolonged PRs. Germany started quite a large trial in 1997, and closed this in 2002, and showed that the antibody alone was somehow superior, but the problem is that this was not a randomized trial. I'll show you a few details in a minute. So I think it's not, we have to consider this with some caution. And the landmark study of LSU with the antibody anti-GM-CSF, IL-2 and retinoic acid, demonstrating that the antibody, that the immunotherapy package is better than retinoic acid alone. And here you see some details of the German trial, which show one is no consolidation after transplantation or with or without transplantation. The second group is maintenance treatment, and third is the antibody, the treatment with the antibodies. And if we then look at the outcome, event-free survival and overall survival, then you see a difference between monoclonal antibody treatment. So this is plain antibody, no IL-2, no GM-CSF, only the antibody. And this shows that there is a difference, a small difference, compared to no consolidation, but not to patients who got some other consolidation treatment. So I know I put some water into the soup, but this has to be considered at least. And what we have, you see that there is anti-GD2 treatment is not a harmless treatment. It has severe side effects we have to consider in treating our patients. And that's why I showed you the short survival time from in patients with recurrent diseases. So we have to balance this. And so fever, cough, rash, pain despite analgesia is quite common in those patients. It can be managed, of course, and we try to manage by pre-treating them, but it's still difficult and it's a burden for the patients which have to be inpatient. This is a landmark study. I think this is the gold standard right now. So comparing the US study, COG, retinoic acid, compared to this immunotherapeutic package. And these are the data I'm sure you are aware of. This is just with the stage 4 disease, event-free survival, with a difference at that time of publication in 2010, and just a hint of better survival, but not significant. Later on, last year, LSU updated these data and showed for all patients, these are including not only the stage 4 and stage 4 patients are here, and this shows you that not anymore the event-free survival is significant, although their figures are some better. Yeah, we have to admit that this is wonderful. But on the other hand, it's not significant only for overall survival. So we have to be cautious. And grade 3 toxicities for the patients is still significant. So pain, fever, infection, electrolyte imbalances, acute allergic reaction, capillary leak, including those who go to intensive care unit, hypertension, and nothing else. I think your patients, your children go to the SIOPEN, and you are aware of this. And there was a randomization between patients with and without aldehyde of IL-2. And think you are aware of it. And these are the data which have been given us lately, or most recently at the conference, at SIOPEN conference, and showing that the efficacy of IL-2 appears, at least right now, not to add efficacy to the anti-GD2 alone. But this was, the early German trial has already this these data. So there's no benefit for this, and there was even no difference looking at the different responses to starting different responses to the frontline therapy. So CR versus VGPR versus PR. And here you see that pain, they needed much more morphine to control the pain. There was a difference between capillarily, fever, hypertension, diarrhea. And there was also a significant fraction or portion of patients where IT was stopped during the treatment, and even one third of the patients could not continue because of side effects. So what we are doing right now is to start a treatment or a randomized trial. First patient is now enrolled, repeating the COG result, so the COG result. You know, it was so difficult to get GM-CSF in Europe because it has to be imported. IL-2 is covered by the insurance and the antibody. So we are now happy to have these three agents together and treat them exactly as the American trial, and have one difference. This is the IL-2. So also IL-2 does not work alone, and it does not affect the antibody efficacy. We still don't know what IL-2 does in the context with the GM-CSF. That's why we need to repeat this, and so we lower the dose, or we change the dose and put them or have a randomization IL-2 IV versus IL-2 subcutaneously, and hope that this decreases the number the number of side effects. You could ask me, why do you do this trial? Because it has been proven. From other parts in medicine, we know that one randomized trial is never enough. And the starting point, for example, we have discussions in the neuroblastoma community about the efficacy of surgery in stage 4 neuroblastoma. Is it effective or not? One trial says yes it is, the other says no it is not. Why is the difference? The difference is the circumstances, the conditions. So you have to also balance for radiotherapy, you have also the balance for chemotherapy. And the German chemotherapy is quite different compared to the SIOPEN treatment and compared to the American treatment. So I think it's not, we don't take it for granted that the results will be the same. Over 18 months of diagnosis, and most of them relapse. No targeted therapies are necessary, and so targeted monoclonal antibodies have been clinically successful, but we think that independent confirmation is necessary, and that's what we are doing. I thank all my co-workers, the whole group, in particular those with the trial office in Germany, and the next trial is together with patients in the Netherlands. And I thank you for your attention and patience.